John Hanalopoulos on behalf of our team, comprised by Marianthi Chiridou, optometrist, and George Esmelis, PhD, and myself from the LaserVision Clinical Research Institute here in Athens, Greece. I will share with you this study where we are looking into our modified Athens Protocol. Basically, all we change here is the sequence between the PTK for removal of epithelium and the topo-guided partial PRK. We're performing the topo-guided partial PRK, as we'll see in a little bit, as the first procedure on virgin epithelium, and then the PTK. And we're using the data from the Vario topolizer, which can adjust for cyclorotation adjustment, and comparing them with previous data of Athens Protocol. So I hope you found this presentation interesting. Protocol seen here, we're trying to normalize the anterior cornea surface as seen here. Cyclorotation is reality, and when the patient is supine, we have to adjust. This is how the Vario topolizer by wavelight adjusts with limbal and iris architecture. This is a report on what the rotation adjustment will be. And on pentacams, we can see the difference on the right, and now before, after, and difference is calculated so we can see what we plan to adjust and what was the actual result. The Vario by wavelight has the ability to image, besides the topographic anterior cornea data, blood vessel pattern at the limbus and iris architecture, as well as pupillary shift and centroid shift. And these data are stored and transferred into the EX500 laser, and thus during the procedure the device can adjust for the new position that the eye has, not only on the XY axis for the treatment, but also cyclorotation wise. And we'll see in a little bit a few examples and also a new description of the same principle in the video. So going to our study, as I mentioned in the first slide, the Athens Protocol, the modified Athens Protocol, has topo-guided partial PRK as the first procedure, as you can see on the far left top picture. Second procedure is a PTK, usually 7 to 7 millimeter diameter optical zone and 50 micron thickness to remove the epithelium, followed by high fluence collagen cross-linking, usually 6 milliwatts for 15 minutes after the cornea has been soaked with 0.1% riboflavin diluted in normal saline, not dextran, and then 10 to 30 seconds mitomycin C soaking. You can see on the bottom left picture how the Vario guided, the placido disc guided data with the X500 excimer laser will adjust for cyclorotation. In this particular case, we can see the cyclorotation adjustment in degrees of arc, 3 degrees, and this will enable the procedure to be performed in a much more accurate fashion. So in order to study how more efficacy we're having with this modified Athens Protocol, we studied 110 cases. This is a very large study with our recently devised procedure to our older data. We matched age and keratoconus with 110 eyes treated previously, where we used a pentacam as Seinflug driven topo-guided with the same laser but no cyclorotation adjustment. And what was common in both groups is that the topography guided PRK combined with higher fluence collagen cross-linking, our standard Athens Protocol. So we were able to analyze the Seinflug difference maps in comparison to the treatment plan. We can see the difference map showed on the bottom right of the 3 color maps seen in this slide. On the bottom left is the actual EX500 excimer laser treatment plan as finished by myself, the surgeon, and in the middle we can see the preoperative Seinflug image. So we're able to obtain the actual difference map before subtracting after from before, and analyze it digitally with our proprietary software, and then be able to create a vector corresponding to the steepest, the peak topographic cornea point, the cone on the preoperative surgical planning map, and the curvature difference map So the calculated data showed us the differences between the peak topographic data and weighted angular difference. Quite complicated mathematically, but in essence we were able for the first time to objectively, with this digitized method, see what the actual effect on these procedures were evaluated with the same device, with the sine fluid imaging analysis device. So we were able to do this in all our Group A cases, the cases with a modified Athens protocol using the Cyclorotation, adjusting vario-guided treatments with the X500 excimer laser, compared to our previous experience using pentacam-driven with the same laser but no cyclorotation adjustment. The data of this analysis is quite interesting. The Group A are recent modified Athens protocol cases with cyclorotation adjustment using the vario-driven Keratoconus treatments with the X500 excimer laser showed a much smaller delta theta of 7.18 degrees with a delta change theta of 3.43 microns difference, where in Group B, without cyclorotation adjustment and using the pentacam, the sine fluid driven data, the numbers were quite larger. Instead of 7.18, 14.50, and instead of 3.43, 10.23, and these differences were statistically significant for both variables studied. And on the bottom, you can see the scattergram. The top one is the Group A, the bottom one is the Group B, showing a much tighter correction with the modified Athens protocol. And on the bottom right, we can see the table placing all the parameters mentioned above, showing the significant difference between the newer version of our Athens protocol treatment. We're therefore seeing that with the addition of cyclorotation compensation, this newer version of our Athens protocol, we call it the enhanced or modified Athens protocol, incorporates a change in the ablation pattern sequences. So now, because we're so sensitive to cyclorotation data and tracking, we're performing the partial topo-guided PRK first and the PTK second. And the rationale is that there's better tracking data with intact epithelium rather than performing the PTK, remove the epithelium first, and then the PRK. Adding the two laser steps together obviously gives us the same result. So no significant difference in which one we're going to use first or second as far as the tissue removed, but in our opinion, a far larger difference in the sequence as far as the ability of the tracker to do so much in the first part, the partial topo-guided PRK, which is the most irregular part and the most crucial for us to be able to obtain the actual planned treatment on the cornea. So we have found that incorporating these changes in our Athens protocol gives us a very large advantage in efficacy of very irregular keratoconus and very regular cornea adjustment on the cornea. And by the way, through this paper and through this presentation, we are showing a new way to objectively analyze the effectiveness of our laser treatments in astigmatism, and in an example of cases are quite irregular, and we see this efficacy greatly increased with including cyclorotation adjustment. Subsequently to submission to this paper to the winter ESCRS, this paper has been published in the Journal of Refractive Surgery, and we're attaching a copy of that publication as well. Thank you very much.